some of those things that the meibum normally, adds to our tear film. Even we're not talking about specifically just lipids, but all of the trophic factors that are within it. So we aren't going to get into all the studies. We'll probably reference a few. Damon and I are, we love our studies, and they're important, right? We want to be able to validate and show scientifically that what we see anecdotally and in clinic is actually happening. And there's a wealth of knowledge, a wealth of not only clinical studies, but or clinical case reports, but studies as well that do show that we have lots of benefits from autologous serum, PRP, PRGF, and these studies go back years, right? This table references back to about 2009 through 2024. I think there might be a 2025 study in there, but this, is not something that's even that new, right? Autologous serum, utilizing our own blood properties, healing properties from blood, has been around for a much longer period of time than just that.
I think it's important to note that out of the different types of biologics and blood-derived products, clearly the most evidence we have in the literature, the most well-studied, is going to be serum tears. I mean, we've got literature, and there's maybe some things that are going to not necessarily always align. This is better in this situation, this is better. There's some back and forth. But if you look at the body of work in blood-derived biologics for ocular surface disease, the bulk of that is serum tears. So it is something that's been vetted, well established. And for me, you're definitely testing the limits of my presbyopia at this point and looking at this slide. But it is for me, it's important to note that those studies are there, not necessarily the nuances and all of the detail in every study. It's like, no, they're well studied, and you certainly can go and do your research. But serum is not a new sort of entity. It's been around for decades.
And not even just within eye care, right? We talk about within eye care, we know it's been around at least, probably 50 years, give or take, right? To some level. And if we start talking about other other disciplines within medicine utilizing PRP and specifically autologous serum has been used even longer than that in injections into different areas of healing to help with more PRPs. But more recently, people are utilizing it within aesthetics to help with collagen production in the skin on the face. So it's a little bit of everywhere.
Anywhere you need regenerative healing, a biologic is one of the things we should be thinking about.
Absolutely. So this is just a really nice slide. I went through it last week, but I do want to touch on it. It's just a great reference back to understanding the differences between autologous serum, PRP, and PRGF as far as how they are made. And with our autologous serum, there's no anticoagulant that's added to the whole blood. It is spun down in a centrifuge after sitting for about 1 to 2 hours. And then it's separated, the clot of the red blood cells at the bottom and the serum at the top. The serum is aspirated, and then it is mixed with typically saline solution, 0.09%, and diluted to specific concentrations. When we get into PRP, PRGF, and PL, all are centrifuged but added with a anticoagulant, and that helps to separate out those different levels. So then you are able to take PRP or platelet poor plasma, PPP, or white blood cells and red blood cells, and in different concentrations, in different facets, they're mixed together to make the PRP, PRGF, and PL. Now, platelet poor plasma, I'm just going to pick on this for 2 seconds because we don't really utilize this. This is mixed along with platelet rich plasma, and it is utilized in PRGF. It really doesn't carry as much platelets. Obviously, it's why it's called platelet poor plasma, right? It does have some plasma proteins, though: albumin, fibrinogen, immunoglobulins, electrolytes, some growth factors. Which is why it's not typically used on its own. It just doesn't have a lot of value to itself. Autologous serum, as I mentioned, diluted with 0.9% saline solution like BSS, isotonic saline. Usually it is mixed into a concentration or diluted down to about somewhere between 20 to 50%. You don't see the ability, or you don't really see anybody going above 50%, and that's because of the positive inflammatory concentrations are higher at that. So the TGBF or TGF beta, when there's too much of it and it's not diluted down, you end up getting suppression of wound healing. Damon, what are your go-to percentages?
So go-to percentages, I would say we used to try to really think about this stuff to do 20, 40, 50. I think, especially as, a lot of folks on here just tell me how to get started is, I think the easiest thing to do is start with a lower concentration, and it really works well for a majority of patients. So I think it's going to be closest to what a healthy biologic tier is with 20%. So I would say that's my go-to. And you talk to some of the folks at Bascom Palmer that are deep in the research on this stuff, and they said there's rarely times you necessarily have to go to 40 or 50% concentration on serum. Now, I think you could look at some of these cases where there's very significant neurotrophic or neuropathic properties to what's going on with a particular patient. But I would say my go-to definitely is 20%. And typically QID to 6 times a day initially. And then as they get better, often it's just BID to QID.
Yep. Very similar. I typically default to about 20%. My neurotrophic, neuropathic patients, I go 40%. I don't use the 50% because the price goes up double.
And you got to give a whole boatload of blood to be able to do that too. And then it congeals a bit. So, I mean, I think if you go too high, it becomes, I wouldn't say counterproductive. It's just a lot more hassle factor for the patient. And you probably aren't even getting that much additional benefit. So I think that in most cases, 40% would probably be my cap. But I think that there's some, I hear patients come in and sometimes 70, 80%. And I'm just like, wow, that you're asking a lot of your patient to do that.
Yeah. Yeah. And there is that concern of why do we do that? Could it still be okay? Sure. But when you've got the higher amounts of the TGF beta, when you've got higher amounts of inflammatory cytokines, because when the red blood cells break down, right, we lysis and we end up with some inflammatory cytokines that come out of that get left in the autologous serum. And in theory, the dilution helps to decrease that. Now, are there studies that look at that? Yes, there are some, but I almost feel like it's a little bit more clinically anecdotal as far as for me. I did try a 70% once at the request of a patient, and we decided that was not going to work for her. Yeah. Now, PRP, because it's utilizing platelet-rich plasma, only platelet-rich plasma. That's the only thing that's being aspirated off. This does contain higher concentration of growth factors and platelets as well, right? It does have it's not diluted with saline. It's dispensed at 100%. Now, this is why, this is something that you do have to take a lot more blood. You do have a higher cost with this as well. As far as I can't get it in my area, but there are patients who've been able to get it from someplace else, and the cost that I hear is higher than autologous serum. What about you?
So I have limited experience with PRP, and I kind of think about this in a similar manner to where I was at with serum tiers maybe 10 or 15 years ago, before we had companies that were national that made this scalable. And I always think about, what I do in my practice is like, could somebody else in another center do this, or someone in a primary care setting do this? And if I don't see that working well for my colleagues, I don't spend a lot of time trying to do that myself, because I think that there's so many patients that need help. And clearly there's a role for PRP, and most people that are doing it in optometry, ophthalmology are probably doing it, in their break room and kind of home lab kit sort of thing. And that it gets into what my point is, it gets the same situation. Why wasn't I doing more serum tears 10 or 15 years ago? Because it was a pain in the butt to do it, right? As patients had to go to a lab, they had to go and transport their own serum to a compounding pharmacy then, and then hopefully the right person is there that can actually get the serum drops to be able to be distributed to the patient. Yeah. And it's a 2 or 3 step process. It takes them half a day to do it. And
unless you're set up in your clinic to do it, I mean, that obviously is, a fix, but I don't have the ability to do that.
Not as most of our optometrists, I think it's just, so I look at PRP as like, yes, there's a role and there's some people that do it and probably do it pretty well. And I have a few patients on it, but the barriers that I had to serum 10 or 15 years ago, which are gone now when we've got these bigger companies that are supporting everybody in every state in the union being able to have access. I think access, sterility, logistics, just kind of operational things make this a challenge. Now, where are we going to be in 5 or 10 years? I'm not sure. But I think that this is, for me, is serum. Why do I like serum much more than PRP? Because I can get it. And it's an easy thing to do. And it's logistically now very possible having vendors that support this so that any optometrist can prescribe serum. Not every optometrist can prescribe PRP right now.
Right. And as things change, you and I could have a very different conversation in 5 years. So who knows? Now, PRGF, this is definitely one of those ones. It's not a lot of places. You can get it at Bascom Palmer. It is much more widely used in Canada. And it's kind of like a PRP on steroids. So after the centrifuge, the platelets are actually activated so that they release more of the growth factors, and they use calcium chloride to help to do that. So you've got higher concentrations of PDGF, VEGF, TGF beta. So all of these things that in theory is kind of part of why we're using it. So even an advantage over PRP. So if PRP is more mainstream in 5 years, this is probably 10, 15, maybe. We'll see. But not something I've had any experience with for any of my patients. And this is just kind of a breakdown. I'm not going to go through. This is very much what we were just saying. Now, percentage is best. We've already kind of talked a little bit about this, right? Ideal, we aim for between 20 to 50, but what are most of us using, right? 20%, most cases for mild to moderate dry eye, Sjogren's, a lot of our patients, this is going to be fine. 40%, maybe more of our neurotrophic neuropathic is where I tend to use it. Some of my more severe Sjogren's patients. And above that, I don't really use it. And we've kind of talked about some of those reasons why. Use and storage. As you said, Damon, most of the time it's about 4 times a day to 6 times a day, depending, and then you'll start to titrate. When do you start to step it back? I had somebody ask that question. When do you start to bring it back to twice a day?
I think it's going to be patient to patient. It depends what else, if anything, they're doing as far as a drop regimen. And I think that the majority of patients, I will tell them we want to do this for at least the next 3 months to have an understanding of how much this is going to impact your ocular surface. And I think that 4 to 6 times a day, for anything that we do, you have to read your patient. And if a patient is like, there's just no way this patient's ever going to put it in a drop 6 times a day, it's like, why am I crazy enough to ask them to do that when it's never going to happen? So I think you got to meet your patient and understand what they're able and willing to do. And I think that 4 to 6 times a day, I know there's people that use it every couple hours, certainly. But I think that, honestly, if you said, if you had, said you have to choose something, I would do 20% QID and just start there. And then after 3 months, seeing how their symptoms are, seeing how their ocular surface looks, then you may make the decision to step back a little bit. Mm-hmm. But I certainly also think, depending on the pathology, there would be some cases where you would say, well, maybe we do need 40% in this case. Maybe this is helping, but we've got an incomplete response. But I think you start out at lower concentration QID and go from there. Now, the bottles you typically have to throw away every 7 to 10 days. So patients are going to want to get their money's worth too. So that's where you might get that 4 to 6 times a day. But I don't think you have to do that for sure.
Yeah, no, absolutely. Use and storage, guys. Yes, it does. Bottles have to be frozen if they're unopened. And yes, they do need to stay in the refrigerator. And that's because you've got a lovely concoction here of all sorts of growth factors and nutrients and no preservatives, right? And we really want to decrease risk of any kind of contamination and growth within. We don't want to risk it, right?
And when you say refrigerated, it has to be cooled. So that means I've had patients that have some sort of almost mini fridge that they're bringing around. Most of the time it's something to keep. What's the hack that you have in Colorado to get people to access or to be able to make their chairs more mobile? There you go. Yeah.
Yep. A Yeti. Take the top off. You can put in ice, or you can put in like just a frozen pack or something, and that'll help keep it cool throughout the day whenever they have to go around and do things. That's usually my suggestion. And for travel, because you can just dump out the ice, put new ice in.
Yeah. So I think that's a good practical pearl for us to use something other than a refrigerator for a lot of the time. But you do store the unopened ones in the freezer. That's what you do.
Yeah, you do have to make sure you do that. Okay, well, let's jump into some cases and when to use serum tears. Like, how do we apply this, right? Where are we going to do this, guys?
So I think that for me, and I'm still probably somewhat guilty of it, is I think we wait too long to think about a biologic. And some of it has to do with what we're taught. Even mainstream things like DEWS 2, which you alluded to, is if you have a dry eye patient, well, don't really care whether they have dry eye, they're all going to be dry eye. And you start everybody with tears and nutritional supplements and a heat mask. And then step 2 is everything RX, everything conventional, IPL, thermal treatment. And then once all that fails, then you maybe do more RX or maybe a specialty contact lens, and then you do a biologic. So we know that was the literature. I mean, that's what we were to go off of. And a stepwise approach like that, it used to be 10 years ago. I was like, well, serum tears, this is the last resort. We tried everything else, and boy, let's go to serum and cross your fingers that they're going to get some relief. And I think that's crazy now when we think about that, when we understand what serum tears are. They're providing properties that mimic our own tears and different growth factors, anti-inflammatory agents that are going to be helpful at protecting the ocular surface, helping it to heal and helping to restore homeostasis.
Yeah.
We understand now that it's a lot easier to get this. I think that was another barrier is last resort, got to do everything else. DEWS 3 this is a driver-based, disease problem. We're trying to, when you and I see a patient, yes, you have dry eye symptoms. How did you get dry eye? What are the different things that are causing the dry eye? And if there's some element that I think a biologic is going to be helpful for, I will introduce that much earlier now than I would have years ago. So
absolutely.
And for sure, it's understanding that this does things that our other conventional agents can't do.
I think 2 other things that have definitely helped me feel more comfortable in prescribing it and prescribing it a lot more: experience and seeing the outcomes and how well it really works for some patients, starting with the stubborn ones like you're talking about, where you've done everything and you kind of just end up there because it's the stepwise approach. And then 2, with copays, right? With copays and high deductibles, honestly, it used to be this kind of astronomical lift cost-wise for our patients. And I feel like now it's almost on par with what the cost is per month for our patients to get their prescription drops in some cases.
And sometimes less even, I would say that, the figure that I quote a patient is typically $130 to $150 a month to be on serum tears. And sometimes RX agents can be, many times that, depending on their deductibles and whether it's covered or not.
Yeah.
So I think that
are they on 2 or 3, and you need
exactly.
You can replace it with 1. Yeah.
And is it doing the same thing that a biologic's doing? Obviously not, because it's going to have a more specific, narrow focus in terms of how it actually works. So,
right.
Where does this actually change outcomes? And I think that you've made a good, point last week and today, Cecelia, is, these are not just replacement for artificial tears. Artificial tears don't have any of these different properties that a biologic has. They're not just anti-inflammatory. Yes, they have anti-inflammatory properties, but we've got other ways to treat inflammation. So they're not solely anti-inflammatory. They've got other things that are going to be helpful. And really, the take home from this slide is this is regenerative therapy. When the eye is not behaving in a way that is responding to conventional therapy, don't try another conventional therapy and another conventional therapy. Step back and say, why is this happening? What is the driver here? And is there something that regenerative or restorative therapy, the ocular surface, could help this patient? So as I said earlier, I'm probably still somewhat using biologics too late. I think I'm getting better. I think I'm getting a better idea of maybe we do one conventional therapy. And now I wouldn't even say serum's unconventional, because now that it's widely accessible, it really is conventional therapy. I think we, as a whole, as a profession, we still push it off to too late. And it's certainly not just an artificial tear. I'm using this when the surface is not responding, or there's a nerve issue, that a drop that's just anti-inflammatory, anti-evaporative, or punctal occlusion is not going to necessarily be enough for this patient. I think this is probably a slide that, I made it intentionally one slide. I think that if you want to take a screenshot, this is probably your screenshot for tonight. And this is a slide that really buckets some patients. And if you think about these patients, you see these more than you think. And I look at the different categories of patients. When do biologics actually matter? When do I have a less than optimal outcome if I'm not choosing a biologic? Bucket one, the surface is not healing. Surface is not healing. Part of our diagnostic is, well, does this patient have decreased corneal sensitivity? We want to understand that. But Cecelia, do you see plenty of patients where you start some sort of conventional therapy, a topical steroid and an immunomodulator, and maybe you did a good job of confirming that their corneal sensitivity was in fact intact, and they get better, but then it comes right back, and they're not necessarily neurotrophic? Do you see that on a regular basis?
I do. Not all. There's probably a couple a week, right, where it's like, okay, well, we did this, right, and then you can't keep them on the steroid, but the immunomodulator is not holding them steady, right, and then you pulse in the steroid, and those are the ones where I'm like, we just need to think about this different.
And I think this is one of our big traditional buckets for looking at a biologic, whether we're looking at a blood-derived or something from umbilical tissue or amniotic membrane, placental tissue. Is the eye not healing like we would expect? Or do they have complications of chronic dry eye ocular surface with filaments on their cornea, where their ocular surface is in rough shape? Or do you simply continue to have these recurrent epithelial breakdowns that tell us that this patient needs a biologic really to have a better regenerative, restorative healing process? So I think that's one huge bucket that is probably still most common, but what are your thoughts on that?
No, I think it is too. And I think that's actually a good indicator that they probably would respond well to autologous serum. Is if you put an amniotic membrane on and they respond, they get better, but then they start to break back down. And whether it's neurotrophic or not, they're going to do well with an autologous serum or a biologic like autologous or PRP, right? Because that's on a day-to-day basis, exposing the ocular surface to all the things that are in that amniotic membrane.
Correct. And amniotic membrane can give you months of duration, but a lot of these patients need continuous therapy. So I'll skip over 2 for right now and go to 3, because we kind of already segued into that. Is you're stuck in the treatment loop. And think about this as an attendee tonight. Do you have a patient where they put them on medication, they get better, then they relapse? Or maybe they had some improvement, both signs and symptoms, when you started an immunomodulator, but then they kind of plateau and they're reaching for artificial tears more. They're like, oh, it seemed to work for 3 or 4 months, but then it's not working. So I think then you don't want to get in the rut of, well, this patient was on the Fitogras and they had a good response and now it's not working. I'm just going to switch into, next generation cyclosporin and crossfade. Take a step back. What are we looking at here? Is this patient really just inflammation or lack of tear production? Is there something deeper here? Then that, cryopreserved membrane or CAM that you talked about, is it works, and then it comes right back. And these patients could have neurotrophic disease. They have, decreased corneal sensation, but not always. And I still think there's a nerve problem. It's just not necessarily that they don't have sensitivity. It's just the nerve isn't functioning like it should. So that's another really key patient type that would be a good candidate for a biologic like serum tears.
Yeah.
So those are our kind of conventional patients that I think everybody that's treating ocular surface disease as an optometrist or ophthalmologist is seeing these types of patients in 1 and 3. 2 and 4, you see them, you probably don't diagnose them as much as they should be diagnosed, especially 2. And then they tend to get into an academic center like Cecelia or into a referral center like myself when they say, hey, I know I have dry eye. My doctor said I had dry eye. But then they said when I look at my eyes, they don't see anything. So if you have a situation where the symptoms don't match the signs and patients have photophobia, they have pain, they have burning, and you look at them and their tear breakup time is normal, there's a nerve issue there. And a conventional dry eye therapy is going to have limited value, or maybe they do have some dry eye, but if they still have these things after appropriate dry eye treatment, take a step back. I think this patient probably needs a biologic. Another one that I see a lot that it used to be somewhat intimidating, but now I feel like we've got a better handle on these patients are these photophobia patients where they have a normal exam. They don't have uveitis, their eyes are white, they don't have staining. Maybe they had a surgical event or some other, systemic disease that they're trying to fight through. But these are patients that clearly need something more than a lubricant drop or more than an immunomodulator. And I think that if someone's had, issues, especially after they've had post-surgical dysfunction of their nerve where something set them off, that's a green light to a biologic. I'm not failing multiple therapies to get to biologic. That's a green light. Cecelia, tell me how you're using proparacaine in your clinic and what does it tell us and what doesn't it tell us? And does it change your decision as to when to maybe consider a biologic?
Yeah, so proparacaine I'm utilizing in respects to proparacaine challenge. If I've got somebody who's got pain, ocular pain, and obviously I don't see stain or I see that the signs and the symptoms are out of line, like I've got a little bit of stain, but I've got somebody who's claiming a 10 out of 10 constant light sensitivity, right? It tells me there's a nerve dysfunction. And even sometimes when we have, these are the ones that really throw us, right? Or when somebody has neurotrophic and neuropathic, right? When you touch the cornea, they don't feel it, but the eye is just, they're just screaming bloody murder for how the eye currently feels.
It's a continuum, and you can have different presentations, and it's not an all or none. Rarely do I have just a neuropathic patient that doesn't have any sensation, and that's all they have. That's much less common.
It's a nerve dysfunction.
Yeah.
This is why it's good to think about it as a nerve dysfunction issue, right? Whether it's swinging too much or too little, either way, it's not good, right? And the thing, though, is that sometimes this can be the trigeminal nerve on the eye, right? Or is this trigeminal nerve somewhere along the pathway? Because you can get retrograde and anterograde issues. And so proparacaine challenge helps us to kind of understand where we're looking at and what we're looking at in respect to some of location of the issue, as well as, how much can I aid in fixing this? Yeah. Because if I put proparacaine on and there's no improvement, right? There's no calming of the nociceptors on the ocular surface, then I'm not convinced that much of what I'm going to do on the ocular surface is going to help this patient.
Agreed. And then another bucket that we see, I probably have a couple hundred Sjogren's patients that I see routinely in my practice, autoimmune patients, rheumatoid arthritis, any sort of neurotrophic keratitis, or somebody has something like graft versus host disease. These patients that have high risk biology are certainly going to be patients you should be thinking about a biologic. So in summary, 1 in 3, clearly every practice. 2 and 4, as you see these patients, your radar gets a little bit sharper, right? It's like it used to be several visits to say, oh, this patient really is, neuropathic pain, or now I get there more quickly based on what the patient is saying and the fact that I know where we're going if we just try our typical therapies. So I think that these are things that as you start thinking about this and asking the right questions, you're going to see these in any practice setting. So let's talk about a patient that I have seen here recently. This is a 67-year-old male who had unexplained photophobia following cataract surgery. Now, this patient had normal conventional surgery, had a monofocal IOL. They saw my surgical colleague, said, I'm so light sensitive. I was a little bit before surgery. Now it's just off the charts. This patient did have LASIK 20 years ago in both eyes. They did have some mild to moderate ocular surface disease. When I saw the patient that we treated with nutraceutical, I use low-level light for some of these patients as it calms the nerves a little bit, but it also helps to improve tear production and it helps to reduce inflammation of the eyelid. And this particular patient also had perfluorohexyloctane. But I treated them and I realized probably within the first 2 visits, like, no, this is not a dry eye issue. This is a nerve issue, because photophobia, if it is something that is inflammatory, you're going to see it, right? They're not going to have normal osmolarity. They're not going to have a wide eye. They're not going to have a lack of staining or lack of cell. If you have a quiet eye that has a lot of photophobia, yeah, you can occasionally have the weird neuro cases that Cecelia is going to see in her tertiary care center, that it is a central photophobia, but I would bet that 90% of these are localized and not central. Would you agree?
I would agree.
So then my thought process for this patient is neuropathic pain or photophobia. I think that's the first point here, is if somebody has photophobia, increased light sensitivity, that is a form of neuropathic pain. Yeah. So we have to let the patient know that their symptoms are real. It's just, I can't see nerve pain. You can feel that. And instead of having pain, in this case, it's simply a lot of light sensitivity. We are going to assess and treat a coexisting ocular surface disease. And then we might do the proparacaine challenge. And if we find that their proparacaine drop, the anesthetic, provides some relief, and we think this is predominantly peripheral neuropathic pain or photoallodynia, that's where I'm going to start with serum. So I think that's where the proparacaine challenge is. It tells me, like, that is a really good patient. If I can get some response peripherally and confirm that's a nerve issue, I got to attack the nerve. And the way to attack that nerve in that case is going to be a biologic. Now, there are patients like this that also can really respond nicely to a scleral lens. And I'll be interested to hear Dr. Kramer, as we do our Q&A, is like, which of these patients do you reach for a scleral lens? Usually if there's an exposure issue or evaporative issue, then scleral lens referral, because I'm not fitting them either in my clinic, that's going to be part of this process for a patient, neuropathic pain or photophobia. Then there's patients that have mixed disease. They have ocular surface disease along with a nerve issue that I end up doing both, and we do a biologic. And if they have significant corneal sequelae, I'll do a amniotic membrane to start, but then these patients often end up having both serum and scleral lenses as part of their treatment algorithm. Any other thoughts for how you would approach this patient?
So yeah, that would be very similar to what I would do. And I think that's a great point, and somebody put a question up, amniotic membrane versus autologous serum. Which biologic do you reach for? And many times for me, regardless what's going on, if I've got an unhealing corneal abrasion, I've got NK, which is probably NK, neuropathic. I'm starting things with an amniotic membrane while I order the rest of it and get them on it, because that's going to be the longer term. And same thing even with like Synedrimen, right? It's my neurotrophic patients. I'm going to do an amniotic membrane immediately. I'm going to order the Synedrimen while I'm waiting for that. And then I'm going to finish the Synedrimen and start them on an autologous serum, probably for anywhere between 8 to 12 months, depending on how long their issue and what their underlying issue is.
I agree. And I think that the second case I want to present will kind of bring that home too. Okay. Is, that photophobia patient that doesn't have corneal sequelae, is like you could do an amniotic membrane. The patient has to pay cash for it. There's not a procedure or a ICD-10 code that's going to be reliably covered in some way that doesn't have corneal sequelae. If they have a quiet eye, we want to use a biologic, because maybe you think, oh, I want to do a biologic on this photophobia patient. So I think the practicalities of that become more difficult, where amniotic membrane is probably 10 times the cost compared to a month of serum. This is another very, very typical patient, though. Persistent SPK. That's all we need to know. Is this patient has staining. They have normal corneal sensitivity. I would say if a patient has persistent staining, you need to test for corneal sensitivity. And I have both the Brill anesthesiometer, non-contact, and I still use cotton wisp. I have a Cochet Bonnet somewhere. I lost it. I bought it with all the best of intentions, but I've never actually used it in clinic. So this patient had incomplete response to lubricants, anti-inflammatory agents. So this is where I think, hey, this is a nerve issue. This is the surface is failing to heal. It's not responding to conventional therapy. So this is where I will reach for a cryopreserved amniotic membrane. And in this particular patient, they got better. They felt better. They looked better. And then they came right back in a month. And I said, well, I can get this cornea to heal, but can we sustain it? And we need to have a plan for something beyond just the amniotic membrane. So then I talk with the patient I think you need an additional biologic therapy. Your cornea is not responding to conventional therapy. It's getting better, but then it's coming right back. And then I have a conversation with the patient. We're going to move towards serum tears. And then we decide, do we repeat the amniotic membrane and then do serum? Some of that's patient dependent, depending on how they responded to that. And in my case, I use one with a cryopreserver with a ring generally. And some patients tolerate that really well. Some people say, I never want that again. So I think there's other things that you can do. I'm very comfortable with cryopreserved and on the ring. But I think that you need a plan for beyond just that month. How am I going to get this patient better and stay better? So I think this is where I can get a nice bang initially, especially if I have corneal sequelae and it's going to be covered by insurance. That's another thing here with membrane. Sometimes it's a little sketchy as to whether this patient is actually going to be covered by their insurance plan to do a $1,500 amniotic membrane in some cases. But I know that they can much more accessibly access more successfully serum tears. So is this a patient that this kind of thought process that you see in your practice, Cecelia?
Yeah, absolutely. Who did today?
Yeah, I would say today. You're probably sure you saw somebody.
Probably at least one today. This was the conversation we had. Hey, you look great after we did the amniotic membrane, but it's not sustaining itself, so we need to go to autologous serum.
Yep. So the cornea can heal, but it's not staying healed because you have a biologic
breaking down
problem, and it doesn't matter how many lubricants or plugs. I also don't think you want to keep putting membranes on this.
No, there is a limit to that, and obviously, legally speaking, someone's going to potentially look at you if you're doing these a lot in one person.
So there's a huge role for amniotic membranes in my practice, but to do them over and over again doesn't make sense to me. I think you have to shift gears. So those are two patient cases. I know you've got a couple here, Cecelia, as we are kind of wrapping up this part, but this is so much fun to talk about this because I think about these patients. This is life changing for these patients when you find the right treatment, and I think it's thinking about, what am I trying to treat? Why is something working or not working? What are the drivers? And does a biologic make sense, whether it's for epithelial healing, anti-inflammatory, nerve regeneration, tear production, all of these things are going to be patients that we should be really reaching for it earlier.
Yeah, absolutely. And sometimes, we think, did I miss it if I didn't do it the first one? It is okay if it's not the first thing you reach for. I've got a patient today that I saw that she has neurotrophic, or she's neuropathic. And so she's got a lot of light sensitivity. She's also an 8-cut RK, PRK. She's had all sorts of things. It's great. I'm like, look, your nerves have been damaged and we already tried these things. And while we've got some of the things under control, your dry eye is under control. That is not the issue at this point. It's your nerves. And so I needed to get my patient there so that I could say, okay, we're doing something cash pay because this is going to be needed. You're going to be on it for about 8 to 12 months. And she said, is it going to be forever? I said, you know what, we'll do the 8 to 12 months. And if we get to the end of it and you say, you know what, cost wise, this is better than going back on the 3 drops that we were on before, that at the cost was about the same, then we'll continue. And if not, then we'll shimmy ourselves back over to something to manage more long-term, which this is one of the patients too. This is somebody who was a little less, what I guess, more of a high issue patient or high risk patient, right? This is just one of my good old general dry eye patients, 35-year-old Caucasian male, complaints, fluctuating vision, foreign body sensation, eyes are red, has Cecelia with minimal MGD. So we started him on at-home good lid hygiene, heat mask, omega-3s, all the things I want to keep the oil moving and, work on that MGD. And I attempted to prescribe cyclosporin and lifitegrast for the patient, but because of high deductible for insurance, it's going to cost them anywhere between $600 to $800 a month. And for whatever reason, we know sometimes we go for the programs and they're great, but the copay can still be very high for these patients. Had side effects with nasal spray varenicline. To be fair, this was prior to cyclosporin 0.1% being available. So I know that is something we take in consideration. But for him at this point, it was nope, autologous serum, and we did a 20%. And I actually didn't even titrate him. We just did autologous serum twice a day for him because that was all that I really felt like he was probably going to need at that point.
Yeah, I mean, this is an aqueous deficient patient, and that's a great patient bucket for serum that has access issues. Is like we got to think about this earlier in our treatment protocol, and I think this is a great case. It's like you didn't try a whole bunch of different stuff. It's like this wasn't going to happen for this patient. Let's do something like serum that's going to provide a lot of healing properties for this patient type, and I think this is a great case.
Yeah. And then this is another one of my trouble children. This is a 70-year-old white female, has uncontrolled Sjogren's and rheumatoid arthritis. Uncontrolled not meaning she's not taking her meds, but unfortunately these patients they're tough. They are tough cookies, and presents lots of light sensitivity and pain, and you can see why, right? We've got some filaments that are there. So filamentary keratitis, 3 to 4 plus diffuse SBK. She's already on cyclosporin, topical corticosteroids, using preservative-free artificial tears every 30 minutes. While there are a lot of different things for her, I kind of just know from the fact of having done this enough at this point that I can probably throw a lot of other things at this patient and they're not going to touch it. So we went autologous serum for her. She had, in fact, already done a lot of those things, right? Lifitegrast, cyclosporin 0.09%, so a higher percentage of cyclosporin, punctal plugs, ointment at night, right? So I got rid of the preservatives in the steroid, and I switched over to preservative-free dexamethasone, 0.1% compounded, and then did a cryopreserved amniotic membrane while we're working on getting the autologous serum in. Again, kind of combining that treatment to kind of get her over that hump a little bit quicker and get her more comfortable, because as you can tell from that photo, she was not particularly comfortable.
Yeah, I think that's a great plan. I think the watch out if you do preservative-free dexamethasone, I have seen some crazy high pressures in a steroid responder with the dexamethasone in this situation. So make sure you're watching their pressure pretty closely. But I think preservative-free steroid, cryopreserved membrane, transition to serum that's a full court press that a patient like this is going to need.
So the last thing I just want to show, because I think it is worth looking at, is this picture. This is a patient of mine going back to talking about neurotrophic and neuropathic, right? This is actually a patient who had issues with healing after LASIK and ended up with stage 2 NK, so a corneal abrasion that was unhealing. And this is actually showing nerve regeneration after about 8 months on autologous serum. So it's not showing side by side of what it looks like and what it looks like. It is actually showing little areas that tell us that there's nerve growth. So the top is actually a new nerve stump. So a new nerve that's growing. And then on the bottom, the arrow is actually pointing to beating off of an existing nerve. So it means it's growth of existing nerves as well. So it's pretty cool, the things that we can do with autologous serum. But in the interest of time, I'm going to, PRP and autologous serum are great alternatives for treatments for our ocular surface disease patients. And I think that Damon's slide on the where to start, the 1 and the 3, right? Those are our patients where we can really make a huge difference, even for people who aren't necessarily severe dry eye. But also then don't be afraid to reach for those things in patients who have NK and neuropathic. Any last thoughts, Damon?
I think it's great. I mean, great cases. And I think that just like with a lot of our treatments is don't think that your patients, that this are my serum to your patients. It's like, these are your serum to your patients, but you got to get comfortable. Mm-hmm. And I also think that if you're just starting to do this, don't necessarily pick your train wreck patient. Pick that 35-year-old like you did that's having trouble accessing RX immunomodulators that needs to have some therapy. That's a really great patient to start on. And I think you can get some confidence. So you got to start somewhere. And yes, you can have the train wrecks, but don't make this a treatment of last resort, because that is not what the current science tells us. Do 3, find the driver, treat the driver. If a biologic is part of it, don't go through all these other therapies to get to a biologic. Go to a biologic.
Absolutely.
Love it. Hey, that was amazing, guys. Great. So good. We have a lot of questions and very.
I know, that's why I wanted to make sure we got to some of these.
But I was so happy when you guys talked about scleral lenses. I like lit up. I was like, let's go.
Did I think about that right, at least in terms of using serum and using scleral for a photophobia patient?
Yeah, for sure. And I think Dr. Koetting, actually, you were talking about that last week too, and putting the drops and the
scleral.
Yeah, in the bowl. So let's see here. For patients currently on immunomodulator drops, would you recommend discontinuing prior to beginning serum tears?
Like a lot of answers is going to be, it depends. If the immunomodulator, lifitegrast, cyclosporin, it has helped the patient feels like there's benefit, I'm going to layer on to start. And then maybe we peel back after we've added. If there's not been benefit, then why are we doing this? Then I'll make a switch. So it's going to be patient dependent.
Yeah, I like to keep it on board a little bit. Again, patient dependent, but I like to keep it on board for a little bit while the autologous serum is getting in there to start doing its job. I hate to pull everything off that may be giving some benefit. If they're not having any benefit, then sure. But I don't want to wait for it to be done to switch over. I'm just going to go ahead and start it at that point.
I love it. And I think there's something to be said about like not starting everything all at the same time, right?
Yeah. Correct.
Okay, this is a really good question. I think we have time for one more. Can you tell us what the conversation looks like when explaining this treatment to a patient?
I'll take that one, Cecelia, and I'll wrap up.
So I'm going to start you on something called autologous serum. Autologous serum is a drop that's made from your own blood. They spin it down and dilute it, and then it's used as eye drops. This carries all sorts of great things in there, anti-inflammatories, cytokines, things that help to nourish the front surface, right? Our blood takes care of us, so it makes sense that if we put it in a drop and put it on the eye, it's going to do the same thing. So this is something not covered by insurance. It typically for a 3-month supply is $4.99 or $6.50 for a 6-month supply through the company that we go through. You're going to have your blood drawn here before you leave. That's our setup. And then they'll get in touch with you and be able to send it directly to you. And then I kind of walk through the nuances of how to keep it. I actually like Damon's thought of breaking it down to how much does it cost per month, because when you do say $4.99 versus $6.50, it is a higher number. Versus if you say it's about $120 to $150 per month.
And the only thing I would add is maybe on the front end of that is usually these patients have been on something, whether it's teardrops or steroids. I'll say, you are not responding to the other treatments that we've done because we're treating the wrong problem. You've got a nerve issue or an issue really that needs a biologic. And the easiest way for it to do that, and then I go into exactly what you said about the process of serum tears and the benefits of it.
Perfect. Well, thank you so much, everyone, for attending. Thank you to our wonderful speakers. Very nice. I learned a ton, and I know everyone did too. Thank you to Vital Tears for supporting this event, and stay tuned to learn more about Serum Tears Made Simple with our sponsor presentation coming up. There's your QR code to get your instant CE. Again, you'll need the OE Tracker app in order to get that instant CE. If you don't have the OE Tracker app, you'll still get your certificate via email, but you can go ahead and scan that. It will not work with your camera. It will only work with your OE Tracker, and I will see you guys all during our sponsor presentation. Thanks again.
Thank you. All right. Bye.
All right, so we're going to start here on the sponsor side. Thank you so much to Vital Tears once again. And Scott Youngren over here with me has 15 years of experience in eye care with regional and national leadership positions in sales, marketing, and training. Tonight, he joins us as the Eastern U.S. Ocular Surface Manager for Vital Tears. Thank you so much, Scott. I'm looking forward to learning from you.
Perfect. Well, thank you so much, everyone, for joining me for the sponsored portion of the presentation. My plan is really to provide you with a brief introduction to Vital Tears and the services we provide. My goal is that at the end of the presentation, you'll register as a provider and join us on our mission of providing Vital Tears to every patient in the U.S. that needs them. So historically, serum tears were prepared by individual doctors and local compounding pharmacies, and as a result, patient access has been limited based on local availability. We formed Vital Tears in 2015 with the mission to provide convenient access of autologous serum tears to patients all across the United States. Our state-of-the-art process means that your patients can have high-quality, customized autologous serum tears shipped directly to their home with a very, very quick turnaround time. We place a high priority on customer service, and our team is dedicated to serving you and your patients with excellence. So let's talk a little bit about the process and how you get started. So to get started, you'll need to register as a provider on our physician portal. Once registered, you simply log into the portal to place the order for your patient. You will need to specify 3 things. So you need to specify the concentration, the number of drops per day, and how many refills you want the patient to have. And from that point, our patient services team will take over. So when Vital Tears receives your order, our patient services team reaches out to the patient to collect payment and coordinate the blood collection. Your patient will have the opportunity to have their blood drawn at one of our contracted facilities nationwide or through a mobile phlebotomist. After the blood draw, the blood is shipped to our facility, our medical laboratory in Kansas City, Missouri, where our highly trained technicians produce the eye drops in an aseptic environment under a laminar flow hood. The tears are then shipped directly back to the patient via FedEx overnight shipping. Our patient services team is there throughout the process to answer any questions your patients have, and then also contact them in time when they need a refill. Now, you have several options when it comes to ordering the serum tiers. So you can get percentages anywhere from 10 to 100%, and the standard being 10 to 40%, and then higher concentrations being 50% and above. And so with a full order, you're looking at about 5 to 6 months supply of serum tiers. A half order, generally 2 to 3 months, and then you have the higher concentration order. The only caveat is that it's important to note that the actual length of time that any order of tiers will last depends on the concentration and the dosage ordered. So our pricing is intended to make the cost of serum tiers manageable for your patients. So a half order should really be considered kind of an introductory or a trial order. And it's $425 with the initial order being $399 for their first order. A full order is $699. It can be broken up into payments of $130 a month. And then a high concentration order is also $699. And that can be broken up into 2 different payments, installments of $350 each. Now, traditionally, serum tiers have not been covered by insurance. However, we're working very hard to work with several commercial payers to secure coverage. And recently, Aetna began covering vital tiers for patients with dry eye disease. Now, we know expanding insurance coverage is a high priority, and it's one for you and for us. And as we know that'll make serum tiers much more accessible for your patients. Vital tiers pricing includes a blood draw, the processing and formulation of the tiers, and then all shipping costs. So that includes the FedEx back to our facility and then back to the patient. So the total turnaround time from when the patient has their blood draw to when they receive their serum tiers is generally around 48 hours. And so again, I invite you all to join us on our mission. Please register tonight to provide autologous serum tiers for your patients. And I thank you for your attention.